I am Dr. Greg Grobmeyer. I was a clinically practicing dentist for a little over a decade in West Tennessee. Went through a cancer battle when I was just 36. Ended up with peripheral neuropathy due to the chemotherapy that I had to go through. And so numb fingers, numb feet, couldn't do the whole clinical dentistry thing anymore. Had to step out of that. Got into practice management consulting for a good long while, worked with offices across the nation. And then eventually got specifically into kind of writing for the dental industry, consulting for the dental industry. That led me to work with Dr. Charles Blair. Dr. Blair, if you have been in dentistry for any length of time, you're aware of who he is. He was kind of the goat, the guru of dental insurance for so many years. And he began writing the Coding with Confidence manual. That's the book series that you see up here above us. And so began writing that many, many years ago. I had the great opportunity to begin working with him and have him mentor me for many years. We did lose Dr. Blair at the end of 2023, November of 23. And so he's no longer with us, but we've continued his legacy. I've been writing the books here and the newsletters and working on the website and all these things for about the last 5 years or so. And doing that. And so it's transitioned over to kind of me being in front of everybody and doing the consults and doing all this kind of thing. So that's where we are and how I got to where I am. And so from there, I want to go to a disclaimer before I get into anything. Everything I'm saying today is it's my opinion. I am a expert in this field. And so if you can call it as such. So I'm a dental coding nerd, and that's what I do for a living. I'm literally writing the middle of rewriting Dental Coding with Confidence for 2026 right now. And so, but it is my opinion. It's not legal advice. Plans differ. Things that I say may work for one plan, may not work for another insurance plan. There's everything's in their contracts, in their language. And that is very specific. So you are responsible for your own use of the CDT, your own administration and dental billing. And so everything, as far as I know, is current as of today. I can't tell you what's going to happen tomorrow. The laws change, the codes change. Things are handed down from the American Dental Association, who kind of oversees a lot of what we're talking about today. And so always code for what you do. Use the most current code set that's out there. But again, this is informational, it's educational. We are not attorneys at Practice Booster. And so I did want to state that before we began. And so now I'm talking about Practice Booster. That's my company. But today I'm actually here on behalf of my supporting company today, eAssist. eAssist is a sister company to Practice Booster. I'd really like to thank them for allowing me to present to you today. I want to tell you a little bit about them before we get into the meat of the presentation. They've been at the forefront of dental billing since it was a concept. And so well over a decade, they're serving over 3,000 dental offices and DSOs. They're verified billing experts on your team, help with the time-consuming and the complicated insurance processes so that your in-house team can focus on patient care and the experience of the patients that are in the office. So they don't get paid unless you get paid. They have zero service costs. Everything is based exactly on what you collect with their help. And so there are no long-term contracts to sign. There's no risk month-to-month agreements is how they set it up. There's no need to change software. They work with all the different practice management softwares, EagleSoft, Dentrix, Open Dental, more than 50 different ones that they have access to. And so they've been doing it for a while and they know what they're up to. They're the #1 leading billing company platform in the nation. To date, look at this stuff on the right here. They have collected more than 22 billion, that's billion with a B, dollars from insurance companies on behalf of dental practices. That's staggering in my mind. And so won a lot of awards. They've been a part of everything. I would like to feature right there, top and center, eAssist is now the official billing company for ADOM, the American Association of Dental Office Managers. And so we will be at their meeting in September. I'd love for you to come up to our table and say hello. But eAssist is just a well-recognized, well-regarded company. but they're not just a billing company. And that's the point I want to get across. We've got dentists out there that they're so happy to refer out an extraction or a root canal if things get too complex, but they're scared to let go of some of the administrative duties and outsource those things to an expert. eAssist is that expert. They are the specialist here. And so this is all they do, and they do it very well. So those of you who are familiar with them, they think of it as a billing company, account aging service, and that's true, but they do a lot of other things also. These services can take up a lot of hours from your admin team. You're paying them for those hours. So outsourcing these services can free up the time of your in-house people to really work on the processes that are best done within the practice itself. So again, the very first thing that you see on the far left there, that's their original focus. It was dental insurance filing and working on outstanding claims, and they do that very, very well. So patient portion statements and billing, this means eAssist has specialists who do statements. They work old accounts, old balances. They're the ones that help collect from the patients. Many practices struggle with those phone calls. That's kind of a hard thing to do. They prefer somebody else to do the dirty work. eAssist can do that for you. A huge time saver is this next one. That's the insurance verification service. It's amazing how much time is used by your admin team just sitting on the phone trying to figure out what benefits are covered by a particular patient. And so eAssist is able to take care of that for you as well. And you can pick any of these different services or all of them together. That's up to you. Accounting and bookkeeping services. That's another tool offered by eAssist. Your practice management software, your merchant statements, they're balanced with your day statements, your EFT deposits, your bank deposits, your QuickBooks. They handle all that for you. They can do deposits and payments. They're accurately reconciled with the bank. And they can even pay bills if you want them to. That's completely at your discretion. Lastly, they have a great relationship with a company called Full Schedule. Full Schedule is a kind of an offshoot of eAssist. It's a partner. They have specialists who actually go into your practice management software. They work overdue recall patients. And so they get that schedule filled back up. Those that have pending treatment, they get them back on the books. And so that is Full Schedule and eAssist. So again, I want to thank them for being my sponsor today. And now we're going to get into the real stuff. I know you're probably feeling like you're at the movie theater and you've been sitting here through all the previews and you're like, okay, when's that actual movie going to start? So here we go. This is the real deal. So the things we're going to learn today. A lot of these, number one, we're talking about the individual errors that lead to delayed, denied, or rejected claims. And these are things that are often fairly avoidable. They're things that can be corrected to get the claim processed and to get it paid. And so we're looking forward to that. Secondly, implementing the best practices for accurate claim submission to try to accelerate reimbursements, optimize cash flow. We are aiming for a clean claim, things that are free of errors without, it's got all the attachments, all the parts and pieces there that need to be there from the very beginning. So lastly, we're going to be talking about the appeals process, appealing to denied or rejected claims to improve those financial outcomes. You don't always win on the first try, but you can come back and you can correct claims, you can appeal claims, and we're going to try to teach you some tricks and things to have success in that process. So let's get started. First, I want to just kind of go through some definitions. We're going to talk first about a rejected claim. A rejected claim doesn't mean that the insurance is denying. A rejected claim means it's coming back to you because there's something about the claim that is stopping it from being processed correctly from the get-go. Now, this can often be incorrect information on the claim form itself. We're going to go into some details about what all that could be. It could also be something missing. We have, AI, we have computers that are looking at these claims. They're looking to make sure if all the appropriate radiographs are there. Are the attachments there? The things that need to be with a particular type of claim, if it's not there, that's probably not even going to make it to a human being. That's going to get kicked back and sent back to your office as a rejected claim without even having seen human eyes. And so these are things that can get corrected and resubmitted and be okay. So next, denied claims. Now, denials are an unfortunate part of what we do, but this means the payer has received the claim and everything's okay. It's all correct. The info's there. That's all good. But the particular procedure that you're asking to be reimbursed for is not going to be reimbursed based upon the contractual language of the plan. It's not covered by the plan that the patient's employer bought. Okay. And so it doesn't mean they don't need the service. It just means that that is not a covered benefit the way that it is. Sometimes it's not a bad enough situation. Sometimes things like that, but it can just be issues with documentation. It can be issues with a misunderstanding, a miscommunication. So we'll talk about some of the reasons for denials as well and what you can do about that. Lastly, there's disallowed. Disallowed is where the contract itself says not only are we not paying for this, you aren't even allowed to charge the patient for this. Usually they will consider certain things kind of an integral part of the service that you delivered. So non-billable services. Some of these things are in the code book, like working radiographs. You can't charge extra for that on top of a procedure. Anesthesia included with a whole lot of the different services that are there from the coding level, from the ADA level. Other parts of this may be disallowed due to contractual basis, meaning the particular plan that that patient has does not, it's got some language in there that it's written so that that particular service not only is not covered, but may not be charged to the patient. And so now there are some things that you can do about that, particularly with a self-funded plan. You can go to HR. You can try to see if they can alter the plan that they've got. But basically, this is what the employer has chosen to cover and not cover. And so we'll discuss that a little further as well. All right, next. This is the big distinction that I want to make to begin with. There's what you can code for, what the procedures are that you do, versus what's actually covered by the insurance plan. Dental insurance is not actually insurance in the same form that medical insurance is. It is a defined benefit plan. There's some guys somewhere in a corporate office that have decided, here's the services that I want covered for my employees. They'll either design the package in-house if they're a very large company, that's called a self-funded plan, or they may purchase a prepackaged plan that's a fully insured plan. And those two types of plans have different laws that cover them. Please research self-funded versus fully insured plans. The state laws only apply to those fully insureds. And so, but the plan design is there. It outlines within that plan contract what things are going to be covered and when. And those certain criteria have to be met in order for that plan to be or for that procedure to be reimbursed. And so just because the patient needs the treatment and it's valid and it's correct and you coded it the way that it should be, you may even documented everything that it should be, it's not necessarily meeting the criteria for reimbursement of that plan. Those are two different things when we want to get that point clear. So why are claims rejected or denied? So let's walk just through these. The first one I'm going to touch on, inaccurate or incomplete information on the claim form. This is actually the number one reason why claims don't get processed. It's due to incorrect patient or insurance information, stuff that's on the claim form incorrectly. So make sure you're using the right claim form to begin with. We've all switched over, hopefully, to 2024 by now. The 2019 claim form is still out there. It's still valid. It's still accepted for the most part. But there's some stuff on the 2024 that would actually help with the adjudication of your claim. And so hopefully you're moving to that. It should usually kind of be done by your practice management software. If you're not submitting 2024, reach out to your practice management software. Make sure that that is updated to the most current claim form. Next, make sure your patient information matches. You can have a patient who you've known as John this whole time, but his real name is Jonathan. Okay. And that's the legal name that's on the insurance card. That should be the name that's in the practice management software, because if that claim goes out and the names don't match, then your claim will get kicked back. It can be rejected. Don't go by nicknames. Don't go by shortened names. Some people go by their middle name. My wife does. She goes by her middle name, but her legal first name is what's on the insurance card. It's what's on all the legal documents. And so make sure you've got the right, correct patient information, including the birthday, things like that. All that has to be correct. If you're off a digit or two, then that can actually throw the whole thing off. Everything has to match. The insurance policy numbers, the plan numbers, who the provider is when you're submitting this claim is super critical. Okay. Not only should the actual provider that was hands-on treating on that date of service, they need to be the one that is on the claim form. Okay. You can have an associate. This is kind of an aside. You can have an associate that's doing the work. They're actually seeing the patient. I see a lot of practice have that situation, but then they submit under the senior doctor's name or NPI number because the senior doctor is in network or they're in network at a higher level. The associate may not be. And so they're worried about that. And they start, they say it's a supervising dentist. That is not okay. Okay. That actually can create some serious circumstances when you're putting incorrect information on the claim form knowingly to try to gain a higher reimbursement. That can cause some genuine issues for your practice. So be very cautious about that. And also specific procedure details. Make sure you've got the right quadrant. Make sure you've got the right tooth number. Every single one of these codes has a particular way that it should be submitted. There's an ADA document called Areas of the Oral Cavity. And you can Google that and see if you can find the most recent version. There should be a 2025, I believe. It's also outlined within the book, the Dental Coding with Confidence Manual. Every single one of those codes has in the end of the comments section, should it be submitted by tooth number, by quadrant, by maxillary, mandibular, how should it be entered onto that claim form? So make sure all that info is correct. That's really going to help things out. Next, untimely filing. So what exactly does that mean? Usually you have a certain length of time in order which you can submit that claim. After that, too bad, so sad, you've missed your window. So it's best practice to go ahead and routinely submit a clean claim with all the attachments, everything that needs to be there, copies of the pertinent clinical record, okay, that needs to be done within 24 hours of the procedure having been performed. That just is going to provide consistency and reimbursement. It's going to give it plenty of time for that claim to get adjudicated, and it's going to get on through there. So pro tip, if you're waiting on primary, you see this thing on the bottom, submit the secondary claims once the primary EOB has been received. You got to submit to primary, wait to get it back, then take that and submit it to secondary. If because primary drug their feet, you're bumping up on that window of when timely filing limit is on that secondary, go ahead and file a claim. File a claim with a note saying you're waiting on primary, okay? You may have to send an amended claim with this, or you will have to send an amended claim, but at least you've made a submission within the timely filing window that can help things move along a little better. So next, coding errors. Of course, this is the one that's really, really near and dear to my heart. This is my particular specialty. So when you're talking about coding errors, there's a lot of things that I want to discuss. Incorrect code for the procedure delivered, big one. People think they may be submitting the right thing, but they're not. I see all the time. I do consulting one-on-one with offices. I do a 3-hour Zoom call where I will review the procedures that were done by the practice for the last calendar year. And by looking at that report, I can kind of tell, looking at ratios and numbers and what's behind the scenes, are things being used correctly? So I do a little 3-hour call where I'll walk through the entire code set and the codes that your practice uses. And I discuss that about what documentation should be there and things like that, but also making sure you're using the correct code for the procedure that was actually delivered. It's amazing how often people think a code means one thing, but it actually means something else, especially if you're just using your practice management software to understand what those codes are. You only see the nomenclature. You only see the first line of what that description of the procedure is. You don't see this big paragraph, this descriptor that goes along with those codes. That outlines a lot more distinct details about what the code is, what it's not, how you use it, what needs to go with it. All of that is built into the code itself, and you never see it if you're just looking at practice management software. You need some other coding resource that kind of lets you see the whole thing. So at least, get the ADA's CDT book, get our book, some similar resource that's got it all listed there, not just the nomenclatures. So incorrect arch or quadrant from the procedure. We just talked about that, making sure that information is submitted correctly. Age definitions. When do you call somebody a child versus an adolescent versus an adult? What are those breakdowns? Make sure that you have an understanding of that and where they fit. Using deleted codes. Every single year, these codes are updated. And there have been over 200 code changes in the last 5 years. We got 60 more coming for 2026. I'm in the middle of writing all that up right now. And so, but we'll see a lot of use of deleted codes when I'm consulting one-on-one practices. And so most practices have 3 to 5 codes that they're using, thinking that it's still a valid code, not realizing that it's no longer actually in the active code set. You submit that, it's immediately denied. It's immediately sent back to you. You can resubmit, but now you're wasting time and money by doing that. You need to know what codes are correct to start with. So submitting office codes, okay? The only codes that are acceptable on the dental claim form are actual ADA CDT codes. They need to be from the most recent code set and all. As a matter of fact, the ADA Coding Companion, page 1, the history section. It says federal regulations and legislation arising from the Health Insurance Portability and Accountability Act, that's HIPAA, require all payers to accept HIPAA standard electronic claim forms. And one data element on that claim form is the dental procedure code, which must be from the CDT code, specifically the version that was in effect on the data service. And there's a code for every procedure. That's the correct and legal language of dentistry, and it's the way that you should be doing things. If you're using a lot of in-office codes, that's not following what ADA says. Essentially, there is a code for something, or you should be submitting an unspecified code. Most of these insurance plans, if you read your contracts, the majority of them will state that all services, all procedures that are delivered to a patient must be submitted to the insurance. They kind of get to make the call on whether it's a covered service or not. And so you need to be submitting those, even if they are unspecified codes, even if they are non-covered codes. If you are in network, you should be submitting those particular procedures. So please do that. Not meeting all criteria outlined in a nomenclature or descriptor. I kind of got into that a minute ago. Those descriptors, sometimes 2-3 paragraphs long, and they'll outline specific things that must be done to legally meet that code. If you're not looking at the descriptors, you're probably miscoding something along the way or not documenting something that could get you in trouble upon an audit. So we don't want that happening. All right. As I mentioned, over 200 code changes in 5 years, 60 more coming for next year. So stay on top of these code changes. Get yourself a updated coding resource annually. It needs to happen. All right. So last part of why claims are rejected or denied, it's missing documentation and attachments. So there's so many parts and pieces to this too. The radiographs, intraoral camera photos. You don't know how amazingly important those things are. A core buildup, you need to be able to show the piece of tooth that's left when you submit that thing. You need to have an intraoral camera photo to go along with that. A 4346 code, having an intraoral photo of those bleeding, puffy red gums, it really, really helps get that claim to go through and be paid. They're not going to downgrade you to a prophylaxis if you're able to show that, hey, this is a diseased tissue state. This is not a normal prophy situation. So periodontal charting, clinical narratives. Now I have this one on here, but the one below it, Chart notes. I note that that is legal documentation. More and more, I'm seeing insurance plans only accepting screenshots of the chart notes for dates of service, which means doctors, if you're on the line, uh, absolutely, it's up to you to be sure that your clinical team, you and your whoever's sitting chairside with you, are entering in correct documentation, that you're saying all the things that need to be said. You know what keywords need to be there, what phrases, what documentation, what bits and pieces are going to medically justify the procedures that you are performing, because it is that chart note that is the legal document, that is the legal record of services performed that day. Narratives don't count. Okay. So you can send in a narrative, but upon a review or anything like that, it's only the chart notes that are going to count. Many of them don't even want to see a narrative anymore. So primary EOB authorizations, those things that have come from somebody else that they need that piece of information to adjudicate the claim, and anything else that's supporting documentation that could go along with that. Sometimes it may be a lab report or lab script. If you've sent in some form of a biopsy, you've got to have that. Those kind of reports from other outstanding providers, that can all be included as well. So a note on the right, no practice is immune to the possibility of an insurance audit. You don't have to be in network. You can get an audit, particular if you're showing particular behaviors that they would flag, certain ratios of procedures, certain particular things that you may be coding a lot of that make you an outlier from the other procedures that are being submitted by everybody else. If you're an outlier, when they look at those data sets, they can come and audit you, even if you are not in network. AI is being used by most all of the payers now. They're using it in a couple different ways. They're using it to look at claims processing. They are checking to make sure all the attachments are there, the verbiage is there. Those things are all included as they should be. But it's also being used to look at radiographs and things like that now. I've seen a big uptick in SRP denials because they're looking for specific amounts of bone loss associated with that claim. And if you don't have the bone loss showing up on your bite wings, then you're not going to get the claim paid. Those particular radiographs have got to show the radiographic evidence of bone loss, or there is not perio present, and that is usually 2 millimeters of bone loss. Now it varies by plan, but that'll get you covered. If you've got 2 millimeters of bone loss, then that's gonna do it. But AI is being used in so many ways, and it's not a bad thing. I always hear people complaining, that this is being done by a computer. It's not even getting human eyes. But that really is speeding up a lot of the processes that don't need a human. It's not a bad thing. They're if they can determine that an attachment is not there, or that a payer number is not right, or that the patient's name is incorrect, without having to have somebody look at that, well, the turnaround gets much faster. It comes back to you quickly. You're able to address those issues. And ultimately, that's going to lead to the claim being paid more quickly. And so that's a good thing. I do want to note that AI cannot, they can reject a claim due to insufficient information, something like that. They cannot deny a claim. AI cannot deny a claim. AI can make a suggestion that something isn't right, and then that is sent to a claims adjuster, who ultimately, the dental benefits consultant, is the one making the final determination about whether or not that claim should be benefited. Okay. So it will, AI can say, yes, this meets everything we need. Go ahead and automatically pay it. And so if you're sending in for a prophylaxis and the patient has prophylaxis benefits remaining, it'll automatically get done without anybody ever having to touch it. AI can do that. Okay, that's a good thing. For the other side of it, if it's determining something is not where it should be, that ends up going to a dental benefits consultant, who is the one who has to make a clinical determination about things. Now, if it's just they've run out of frequency, something like that, that's going to be automatically adjudicated. So there we go. And you can see, and these numbers are from a couple years ago. I guarantee you it's higher than this now. Just about all of the payers are using AI in the adjudication of claims. So, what exactly is a dental benefits consultant looking for? And who are these guys? Who are they? What are they doing? And most of them, please don't get ugly on the claim forms with the benefit consultants. What they are doing, they're usually guys like me who were probably practicing and something has taken them out of the clinical realm, whatever it might be. For me, it was a cancer battle, but if you're not doing hands-on dentistry anymore, you're looking for something else to do. A lot of them become dental benefits consultants, and then they are not making clinical determinations. Again, I mentioned this earlier, not making clinical determinations about whether the patient needs the treatment or not. They are making determinations based on their little book of particular criteria that have to be met. Does the patient meet that? And so here's what they're looking for. They're looking to make sure that the procedure, first, was it actually performed? Okay, you're not just turning in a claim to gain reimbursement for something that wasn't actually done. You wouldn't believe how often that actually happens. Shouldn't, but it does. Was it medically necessary? So that's all the documentation that needs to come from the clinical side for radiographs, for intraoral camera images, for some good SOAP notes that are written in your clinical chart. That documentation needs to medically justify the delivery of the procedure, shows that it really needed to be done. Was it cosmetic? The vast majority of insurance plans will not cover for cosmetic procedures. So if it's something just to improve the aesthetics of the patient, it's not a thing that they're likely going to cover. However, there are a lot of plans that do. The particular employer, the design of the plan, it can be made to cover whatever you want it to cover. And so if that particular employer wants their employees to have coverage for veneers, for bleaching, for whatever it may be, then that may be allowed. Okay. Also, you are ethically obligated as a provider to disclose in the claim form if it was a procedure that you did just for aesthetics. If you did some big 4+ surface composite resins on number 8 and 9 to close a diastema, close a big gap on the 2 front teeth, you are supposed to, from an ethics standpoint, disclose that to the insurance company. The insurance company does not have an obligation to pay for those particular procedures. And so now that is a thing that's not policed. It is an ethics thing. It won't come back to get you unless upon audit they figured out that was happening. But certainly, if that's something that's going on frequently within your practice, it can raise an audit flag. They'll begin looking at you a little more closely. So they do kind of grade you. They do look at you and the procedures that you're submitting. Are there any particular questionable things on here? The more questionable things you submit, the more scrutiny that they give to your future submissions. And so be very cautious about that. Was the procedure upcoded? So upcoded essentially is, are you charging a higher procedural code for a thing that you did? Let's use the example of a 7140 simple extraction versus a surgical extraction. I'll see a lot of practices that just because they lay a flap, they call it a surgical extraction. That is not true. That is not correct. If you look at the code language, the descriptor of those particular codes, it clearly states that it must, to be surgical, it must have bone removal and or sectioning of a tooth. And so if one of those things is not happening, then it's not a surgical extraction. Laying a surgical flap does not make it a surgical extraction. And so if you're calling those things a surgical extraction when it was really a simple extraction, then that could be construed as upcoding. So what is the claim form submission accurate? Is it actually a great representation of the procedures that were actually performed? By looking at your clinical documentation, a lot of times they can tell, is what you did correct to match the code that was put onto the claim form? So they want to make sure that what you're saying you did matches up with what is in the clinical notation. So another reason they want to see the chart notes, right? So was the using the most current CDT code in effect at the time the procedure was performed? The code language changes every single year. Like I said, I make a living off of discussing those changes and coaching practices on that, talking about what all the distinctions are, the little nuance between this code and that code, and they alter it. Sometimes they change codes that you've been using for many, many years. They go through and they'll take D0210. Let's talk about that full mouth series. And so they altered it. I think it was 2023. They went back and changed the descriptor on that code so that it didn't have a particular number of images that were required, but it did say that it had to include, let's see, crowns and roots of all teeth, interproximal areas, periapical areas, and it must have periapical bone, including edentulous areas. It's got to show the root surfaces, the areas where there not only are teeth, but where there used to be teeth. That's in the nomenclature now. If you're submitting a full mouth series that's missing some places because there aren't any teeth there, that's actually not a full mouth series. Okay. It doesn't actually meet the definition of the code anymore. And so haven't seen anybody get in trouble for that, but in theory they could. Okay. That's a simple version of this, but there are lots of updates to CDT codes, little nuances, little things that you may not be aware of. You got to stay on top of it because they can come back and get you, particularly if they're in there doing an audit. Most of the time, they won't do an audit for something small. They'll be looking for particular behaviors. But if they're in there doing an audit, they're going to look for every single thing they can find. Okay, so submitting for radiographs that weren't diagnostic, or if you're not writing that radiographs were needing to be diagnosed or for a reason, that they were taken for a reason, not just because their insurance is going to cover them now. Okay, there needs to be something in the chart stating that the doctor prescribed those radiographs. Okay, so documentation is very, very critical. Let's look at some clinical examples. I'm going to walk through some of this. This 2950 core buildup is the most denied service in all of dentistry. Okay. And there's a reason why. There are a whole lot of dentists out there that were submitting essentially a core buildup every time they touched a burr to a tooth to do a crown. If your crown count is essentially equal to your buildup count, rest assured that you're probably on a list where they are really watching you closely. If you haven't been audited, you're probably a candidate. Okay. And so not all teeth that you do a crown on need a buildup. The definition is very specific. The definition of a core buildup, if you look at the descriptor, it says it refers to building up coronal tooth structures when there is insufficient retention for a separate extracoronal restorative procedure or crown. Okay. So insufficient retention. That's the only time you can do a core buildup is if there's not enough tooth left after taking out the old restoration and the decay. There's not enough tooth left there to hang a new crown on and make it stay. So you're going to have to do a buildup. So it goes on to say a core buildup is not a filler to eliminate any undercut, box form, or concave irregularity in a preparation. There's another code for that, by the way. That's D2949, restorative foundation. They're never, ever paid for, essentially. But that is where you're just kind of blocking out undercuts. Okay. So there is a code for that, but it is not a core buildup. A core buildup is specifically, and I have it on the slide there, necessary for the retention of the crown. So this needs to be in the clinical note. If you're sending in screenshots of the notes of date of service, this needs to be in the clinical record. So these things need to be in the auto notes, in the templates, whatever it might be, that you're using to create your individual clinical note for that particular patient. Now, make sure that it's not rubber stamped, that it is individualized to the particular patient. So that's going to be necessary for it to hold up in a court of law, wherever that taken to that extreme. So necessary for the retention of the crown. That's number one. Put the words in there. They're looking for the word retention. They're scanning for that word. Needs to be in there. Okay. Most insurance companies define that need as being more than half the tooth structure missing after removal of old restorations and decay. And so if greater than 50% of that tooth structure missing, you can state in your clinical note, 65% of tooth structure missing after decay removal and old restorations were out and whatever. And so there just can't be much tooth left. Intraoral photos are critical in showing that also. I want you to take a picture. First off, before you ever do a crown, take a photo of that. That shows cracks, fractures, large restorations, things you can't see on a periapical. Okay, things you can't see on a radiograph are going to show up in that intraoral camera image. So that justifies the need for the crown. Then once removing the old restorations, taking out the decay, even some preparation, you need to take a intraoral camera image of the shell of the tooth that's left to show that's going to medically justify the need for that core buildup. You're going to show them that there's just not enough tooth here remaining to be able to put a crown on and have it retained. So that's when a crown core buildup is necessary. So symptoms, prognosis, let's talk about that. If you've got a tooth that is showing some bone loss and it's been maybe SRP treated, state that it's been treated for periodontal disease, state that it's not mobile, that the patient is not having pain or discomfort. Say that you feel the long-term prognosis is favorable, that it's good. Same with a tooth that's been root canal treated. If you've got one that's showing a little bit of periapical pathology, it's great to mention that it is not percussion sensitive. It's not symptomatic. This root canal was done 10 years ago and it's holding up great. And so this is a little artifact that's there, but you feel like the long-term prognosis is good. All those things need to be in the clinical notes so that that can pass all the way to the claims adjuster on the other end. So all that needs to happen in order to support the documentation for a core buildup. Now, sometimes core buildups just get rejected. A lot of times they get rejected on first submission, almost as a way to see if you'll appeal or not. Okay, I swear that happens. It shouldn't, but I feel like it does. So always resubmit. Only about a third or so of claims are ever appealed, and that's a shame. They need to be appealed. They need to go back through. You need to make sure you've got all the supporting documentation, and a lot of those get paid upon second submission. A lot of times what they're waiting for is a seat date. A core buildup is in and of itself not a definitive procedure, okay? And most of the insurance policies have something in there called an incurred liability date. That means when are they on the hook? And they are usually on the hook only when a procedure is completed, okay? That means a seat date when you're talking about a crown, things like that. It's the same with a core buildup. A core buildup is not actually completed until the crown is sitting on top of it, because this is a step along the way. It is not a procedure in and of itself. And so they're waiting on that seat date in order to be able to adjudicate that claim. Again, and I get this question all the time, when do you bill it out? Things like that. The patient is responsible for their part, and essentially the whole thing if insurance didn't pay. They become financially responsible upon that first visit where we're doing prep and impression. Okay, so that's their part. It can go on the ledger at that time. However, the insurance is not responsible for their part financially until the incurred liability date, which under most plans is completion, the seat date. fact, a lot of them say don't even submit it until the seat date. They don't want to see it until the seat date. If you submit it, usually what they're going to do is come back with a denial, and now you've just wasted everybody's time essentially. And so they're kind of waiting on that seat date. You call back with the seat date, or you resubmit the claim with the seat date, then you can do that. You can also, put a note on there that you expect the crown to be seated on such and such a time period. That can be in a remarks section, box 35, if you wanted to put that on there as well. So that's getting core buildups paid for. Let's look at another example, D4346. D4346 is it's the scaling in the presence of moderate to severe gingival inflammation code. And so this is a gingivitis code. Now you'll note that this is in the periodontal category service. It's not preventive. This is not a glorified prophylaxis. This is for the treatment of a disease process. And that needs to be made very clear, not only to your patient, also to the claims adjuster. Taking some photos, show that bleeding, show these things that are here. Your clinical note needs to demonstrate that bleeding is present. Okay. Bleeding is an indicator of inflammation. That means active disease process is going on. Now, D4346 is specifically defined by generalized, moderate to severe. And so generalized is defined as 30% or more of the mouth. 30% or more of the teeth have a bleeding point. And Mark, you can see the example that I've got there. If 30% or more of the teeth have at least one bleeding point, then you've got an indication where 4346 could be used. If there is no bone loss, if bone loss is present and you've got all that bleeding, then you got yourself periodontal disease. That's the next step. We'll talk about that in a moment. So, but for D4346, you're wanting to demonstrate that there is no bone loss, but you do have the bleeding. Generally, they may require 4 or more millimeter probing depths. That's from swelling, from inflammation. Okay. So that's not from bone loss. That's not the bone going down. That's the gums coming up. They're getting puffy. They're getting inflamed. So that's essentially what D4346 is. Taking some of those intraoral camera images, it's so good to be able to show some bleedy, puffy, gross them out a little bit. Let them see that this is not a healthy mouth, okay? This is a disease process that you are treating. Now, D4346 is often followed up about a month or so later with a prophylaxis, if appropriate. If the inflammation has kind of gone down, you can then do prophylaxis. D4346 also often shares frequency with prophylaxis. So what you're doing is in a 1 month period of time, you're burning up 2 prophies. They usually only have 2 a year, okay? Some point, there's going to be an out-of-pocket prophy for that patient, and they need to be kind of informed of that on the front end to know what to expect. Let them know you're playing catch up. Let them know that you're aggressively treating a disease process that's a reversible disease process, but you're trying to prevent it from growing into this irreversible disease process where you're losing bone around your teeth. Scare them just a little bit, okay? Your patient needs to understand the weight, the gravity of this. Don't call it a deep cleaning. Let me say that again. Don't use the words deep cleaning. What a patient hears when you say deep cleaning, you're saying cleaning, but maybe a little more. Okay. It's a prophy, but maybe just a little bit more of one. That's not what this is. It's a completely different thing. And they're going to get mad when they have to pay a patient portion on a D4346 because you're not differentiating it. Okay. And especially when it comes to periodontal disease, if they're thinking prophylaxis and you're having to do all this other stuff, the patient's not happy. Treat it like it's 2 separate things. Okay. Don't connect those 2. All right. Next, scaling and root planing. So I mentioned this earlier. The diagnosis of scaling and root planing really hasn't changed. We're still using the staging and the grading and the clinical records that we always have, the probing depths, the furcation involvement, mobility, all this kind of stuff. But the submission requirements kind of have changed. The things that a payer is looking for has altered a little bit. You're using either the D4341 for the 4 or more teeth or the 4342 for the 1 to 3. So D4341 is purported by quadrant, whereas D4342, they're requiring quadrant and tooth number. Now, I actually like you to put some tooth numbers even on the D4341, because if you're treating 4 or more teeth in that quadrant, you're treating 4 teeth, but there may be some others that you are not treating currently as periodontal disease, and at a later date, those teeth suddenly have bone loss. Then you've got an argument that the patient needs another treatment of SRP, because now we have teeth that were not involved in the first delivery of SRP, which have now progressed to needing periodontal treatment. So consider that. Essentially, 4 or 5 millimeter pocket depths, that used to be the indicator. That used to be the thing that got it paid. Okay. No longer. You can have a 4 or 5 millimeter pocket depth with no bone loss. We just talked about that with 4346. Okay. It can be from inflammation. 2 millimeters of clinical attachment loss. That's what payers are wanting to see. They're looking at your radiographs. They're looking at your bite wings. They're wanting to see 2 millimeters of bone loss. If that's not there, then they're not paying. Okay. Now think about this also. If you've got an assistant taking bite wing radiographs, that's what they're using to look for bone loss. If it's the least bit canted, if it's the least bit up or down when they take that image, that's what we call foreshortening the image. It makes it a squatty picture. And suddenly your 2 millimeters of bone loss only looks like 1.7, and your claim's not getting paid. So you need good diagnostic quality radiographs. I really suggest pulling out the rings, lining that up, making sure you're getting a good perpendicular bite wing when you're trying to submit these things. Bleeding on probing. So that's the other thing. We got to have bone loss. We got to have bleeding. Bone loss means it's periodontal disease, not just something else like 4346. Bleeding means it's an active disease process, not just that they had some bone loss in the past. Okay. Active bleeding needs to be happening before a scaling and root planing would be a productive therapy to deliver. Start times and stop times. This is new. They are now asking for either duration of treatment or start times and stop times to be in the clinical notation. There are a lot of doctors who are out there trying to do 2 quads of 4341 in a half hour. That's not right. Okay. That's shady. Because of that, because of the actions of those people, we now have to do more documentation to verify that we are giving enough time on our schedule for a quality delivery of a scaling and root planing. So start times and stop times are necessary, as well as types and amounts of anesthesia. Types and amounts of anesthesia. If you've got enough root surface showing that root planing can happen, that can only happen if the root is showing, right? Then essentially digging down that deep under the gums is uncomfortable. You're also potentially moving away some diseased tissue. That requires anesthetic to be treated properly. So if something else is done to numb that patient, like Oraquix or something local, okay, note that in the chart, submit that. But a lot of times they're only paying on these claims if full local anesthesia or nerve blocks and things like that are being done. So be aware. Those things need to be in the clinical notes now. Okay. We're coming up on time, but we're about to wrap up. When should you appeal and what should you appeal? Essentially, you need to know the coverage. Okay. You know that the patient needed the procedure that you delivered. Okay. Or you wouldn't have done it. At least I hope so. But that said, doesn't meet their criteria for payment. You're going to need to know the patient's coverage. And this may be requiring great insurance verification. Is it a covered service? If it is a covered service, what criteria need to be met in order for that particular code to be reimbursed? And so those are the things that you got to know. You got to know your frequencies, your limitations, your exclusions, those particular things that can be found on the plan document of the plan, the policy processing manual. If you can get your hands on those, it's super helpful. It's a lot easier to win a game when you know the rules. Okay. Absolutely. So when should you appeal is when you know you got it right and it looks like it ought to be a covered service looking at their limitations and exclusions. Okay. If you can look at their book and say, hey, it fits this. Okay. They haven't had these performed in the past. This is not an excluded benefit. Then you know how to cater the language. You're able to send it in the appeal. Hopefully that would be passed upon second submission. Sometimes it's honestly what claims adjuster is looking at this, whether they're going to give you the benefit of the doubt or not. So that's there. The EOB should have details on it about appeal instructions. Note that sometimes where you send the appeal is not the same place you sent the claim to begin with. There may be a different address, a different place where you were sending this information to. So be sure that you have that correct, that you're sending it all into the correct spot. Okay. So with that, again, I want to go back to a quote by John Wooden. If you don't have time to do it right, what makes you think you'll have time to do it over? Okay. Don't take shortcuts on your documentation. Don't take shortcuts on your submission. Make sure you're doing it right the first time. It's going to save you time and money in the long run when you're not having to do it over. Okay. So that kind of wraps up our presentation. I do want to offer you something. I've mentioned throughout our program that we do the Coding with Confidence manuals. We also have our online version of this, and that is our Code Advisor. Code Advisor is the online database. It's got all the information that's in the Dental Coding with Confidence manual, but it's searchable. And so you can look it up. You can look at it on your phone. You can look at it on your computer. It's got all the same information that's in there. It's updated. If there's a change mid-year, well, I can't change the book until next year, but I can change it almost immediately on the website. And so the website also gives you access to a few other things like our call center support. You can call and ask a question, and I will answer the phone and talk to you about it. Okay. And so those things are available for you. You can get 15% off of Code Advisor right now from this particular webinar. I've got the date here as the code. That is 7/23/25. That's today's date. So using that code, if you go to that particular activation link that I have there on the QR, then I am happy to give you that 15% off of Code Advisor. So love for you to join us there. I do want to open it up. I don't see any open questions. We're right at the top of the hour. If you've got something you'd like to discuss, I'm happy to do that. If we miss it, then if you're still submitting, hopefully we'll get back to you after the fact. So since I don't see any open questions, I'm going to go ahead and put it here. If you want to get a copy of our books, you can go to dentalcoding.com, find it there, talk right here to your Henry Schein Business Solutions team. Henry Schein will be happy to get you a copy of our book as well. It's in their catalog, and so they'd love for you to purchase it through them. Scan that QR code. They can get you a consultation. They can talk. You can talk with the Business Solutions team about all the different services that Henry Schein offers that can help your practice be profitable, to grow, and to move into the next century. I've really enjoyed speaking with you guys. It's been great. That kind of wraps us up. Is there anything else that we need to discuss? I'm going to throw back to you out there. Nobody's got an open question or anything. So, okay, guys. Well, I think we're going to call it for the night. I greatly appreciate your participation in this webinar and listening to me for the last hour. And so thank you so much for all that you've done. And we will see you next time. I greatly appreciate it. Thank you, guys.